Blog Talk Radio.
And welcome to another edition of Carnivore Radio. I'm your host, Jeff Sherman, along with the esteemed Dr. Eric Lopkin, and we have a true doctor on the show, Dr. Cannizzo, who works in the Hartford healthcare system as an oncologist. We've had him, Dr. Lopkin, when we were on terrestrial radio. And welcome to Carnivore Radio.
Well, thank you very much. Thank you for the invitation. I'm really happy to be back.
Awesome. Now, before we get into some of our discussion points, fill us in a little bit. You can introduce yourself to our audience and also talk about your great adventure that you've been on for the last extended period of time.
Well, my name is Frank Cannizzo, and I was the Director of Surgical Oncology for the Hartford Healthcare System. I should have filled you in on this, but I've since moved. I'm now the Chief of Staff for the Salem Veterans Administration Healthcare System in Salem, Virginia. So I'm at the base of Blue Ridge
that's
now.
another show. You got another show locked and loaded. That's awesome. But I think it's still quite relevant. So let's talk about a recent adventure before we kick things off.
Well, I got deployed with the U.S. Army in August, and I got assigned to a forward surgical team supporting the 7th Group Special Forces in Kandahar, Afghanistan, and it was fairly exciting. I have to admit, the guys I was with were extremely high speed. They were, this was as a forward surgical team, this was their second time around supporting special forces. And, I don't have to tell you, but the ODA guys, the special forces guys themselves were just an unbelievable group of human beings.
Yeah.
And how I choose that word very specifically.
And I'm sorry, but how did you get involved in that? I mean, it's a logical question. It's not something that would, happen every day. So let's talk about that.
Well, I joined the military in 1990. I just passed my 31st anniversary as a reserve medical officer. I served in the infantry. I was a medical officer for the artillery, for the armored cav, and most recently, for the last 20 years, I've been a medical officer serving in hospital units and small forward surgical units. So this was my sixth deployment. So
and
I've been
it turned out to be quite an adventure, didn't it?
Yeah, actually,
in terms of logistically.
It was a nightmare with the drawdown in Afghanistan. Rather than collecting up people who were losing missions and sending them home, in the wisdom of the Army, we all got recycled to new missions. So my sub team got reassigned to Africa to support an air base in Niger, which in turn was supporting a sort of special operations State Department mission. So it was quite a trek and quite an adventure. I got to see a lot of the world.
That's really fantastic, and we certainly appreciate your service. Dr. Lopkin, any thoughts?
Well, first of all, given the switch in your mission, one, how did you pivot to the new circumstances? And two, I'd love to hear what kinds of health problems they're facing in Africa that you had to deal with.
Well, that's a good point. Both of those are extremely important and weird questions, only because the Army is basically set up as major commands, major theater commands, so that Central Command, or CENTCOM, manages its own house across all the services that lend forces to that mission, the Army, the Air Force, the Marines, the Navy, the whole bit. And now I guess the Space Force, too. I should mention them, too. But the sharing of forces, the sharing of resources between different major commands like Central Command and AFRICOM is something that's really very unusual, and the logistics of that are not well worked out. So, I mean, we basically, the word came down, get your stuff, pack up, you're going to go back to Germany, catch a plane for Africa, and it all sounded very kind of worked out. In fact, like nobody along the way really knew how to accomplish what we were supposed to be doing. So it was, we kind of, I think we participated in writing the rule book for changing theaters mid-deployment.
And what kind of situations were you dealing with in terms of Dr. Lopkin's question, injuries and, what you had to deal with? I'm sure it was pretty far-reaching, very extensive.
Well, it was. And the part of Niger we were in was fairly quiet. We were not in the kind of, we arrived kind of all hyped up from being in Afghanistan. Our attention level, our focus level was very, very high, obviously, coming off of that mission. And we got to Niger, which is equal parts a humanitarian mission and kind of a civil support mission, support to the civil government mission, with really no combat component to it. And it took us a little while to kind of recalibrate our sensors to, sort of ease into teaching the Nigerian military people and liaisoning with them to do joint medical missions, to, kind of ratchet down our own excitement level and kind of get back into the training mode of what we do. And it was a lot of training, teaching, educating for our third country counterparts, but also, when there were severe issues, they would call on us. Now, Niger has a fairly mature medical establishment. They can take care of a lot of stuff, but their hospitals are not very well resourced. Their turnover of medical personnel is pretty high. So we had a couple of incidents where there were, say, multi-vehicle accidents with lots of people who were injured in many different ways. That stuff would immediately come to us, and we'd have to do the sorting and the treatment of the more severe casualties.
Interesting. Before I throw it out again to Dr. Lopkin, excuse me, but from the humanistic standpoint, talk to our listeners a little bit about how did the relationship develop between both of you? You coming in there, was there maybe some initial resentment or skepticism? Talk a little bit about how that evolved.
Well, we've been in Niger for many years now as part of the West African support mission. There are, some strategic initiatives that the U.S. military is pursuing in West Africa, just like there are strategic initiatives we're pursuing in East Africa, in Somalia and Ethiopia and Kenya. So I wasn't really there at the outset. There's already a pretty well-established relationship between the U.S. military and the Nigerian military. But I can tell you from other experiences I've had that, there's a lot of there's a lot of dancing, there's a lot of face-off that has to happen before those kinds of relationships are built and strengthened.
I'm thinking in terms of even, the most basic relationship in terms of like a business where, consultants come in or other people, outside entities come in. They're usually or sometimes is some type of a resentment and, or maybe pushback. And I was just curious if that happened and was it resolved?
I'm sure that it happened. The culture of the U.S. military is such that we rarely mince words. It's very streamlined communication, and we all inside that structure understand that, it's not necessarily somebody being unpleasant, but it's the most efficient way to tell the greatest amount of truth in the shortest amount of time. And sometimes it's not as diplomatic as it ought to be. So the initial development of third country and partner relationships happens through people who have special training in how to kind of soften that message a little bit so that we come across as having real value for them, but not necessarily, hitting them in the face with it. If you know
sure,
what I mean.
And I'm sure that happens in terms of dynamically in the person-to-person relationship in terms of your interactions with other people as well, correct?
Absolutely. It's, when you step down from a place like Afghanistan to a place like Africa, in terms of, and by down I mean in terms of the intensity of the mission, it does take a little forethought to, choose your words carefully to kind of ease into new relationships.
Makes all the sense in the world. Dr. Lopkin?
Yeah, Doctor, can you tell us a little bit how your deployment, if at all, was affected by the COVID pandemic?
Oh, well.
Amazing question. Yes.
Oh, my goodness. It was. So let me start at the beginning. So the way that units are deployed in the United States military, units that include healthcare professionals, is that there's a place, usually like Fort Hood or Fort Campbell, where the unit goes to prepare, to do their training, to get equipped, to get certified to go overseas. And then there's a separate place, right now it's at Fort Bliss in Texas, where individuals like myself and Major Justin Town, who's my CRNA counterpart, go to get individually prepared, and then we kind of meet up in theater and form a complete unit. That used to take about 3 to 5 days to get in there, get certified, get your papers signed off, and get out on the next plane. And now it takes 14 days. The problem is, if there's one piece of that whole puzzle that doesn't get done, that doesn't get signed off in time, you got to wait another 14 days. It's not like just a couple of more days. You have to wait another whole cycle. So I was in prep for 28 days, which was awful. I finally met up with my unit in Afghanistan, and we stayed there throughout the month of September. And then getting, I had told you a little bit about the logistical issues with getting through Germany and into Africa. We were only supposed to be there through the third week in November. Problem was our replacement unit was stuck in this endless cycle of quarantine and movement that left them in the United States. The units are supposed to take 30 days, no more than 30 days to out process, including their quarantine. and the providers are not supposed to take more than 14 days. Our unit was in quarantine for 56 days. So we were in Africa through the 22nd of December. So it was a little bit more than a month after when we should have left because of the additional logistics imposed by the COVID quarantine. And it's upsetting, but it's really unavoidable.
All right, we need to take a quick break, but we'll be right back.
To reach the next level, you need to operate at peak performance. The key to this is mastering the 7 elements of success. Learn how to master mindset, focus, operations, communications, innovation, evaluation metrics, and continuous improvement. Get the Biznetics Way at Amazon, Barnes & Noble, Books A Million, and bookstores near you.
And we're back, and if you'd like to be part of the conversation, you can call us at 563-999-3693. That's 563-999-3693.
And we're really very, very privileged to have Dr. Cannizzo on, just getting back from Africa. And thanks so much for being on Carnivore Radio, our national podcast. Getting back to more domestic issues, with the whole pandemic, you're an oncologist. Very, very difficult situation, I'm sure. It's almost impossible to articulate it, but can you walk us through a little bit about how the pandemic has affected your normal practice in terms of oncology and treating cancer patients?
Well, yeah, actually, it's something I've been very, very involved and interested in, in my current position at the VA. The COVID pandemic has slowed down every aspect of medicine. And for better or for worse, it's forced us to reevaluate everything we do from a new perspective. So cancer therapy, I think, and I'm biased because I'm a cancer surgeon and I'm a little bit close to the subject matter, but I think it's a unique form of medical therapy. It's not exactly emergent, but it is something where the schedule is everything. Sticking to the schedule of cancer treatment once begun is extraordinarily important to the outcome. And it's the schedule of cancer treatment that the COVID-19 pandemic is really screwing around with, because one of the pillars of trying to reduce the transmission of COVID-19 is maintaining social distancing and reducing unnecessary visits to common areas like medical offices and hospitals and clinics. So we're trying to empty out our clinics and transfer visits to telehealth and virtual care at the same time that we have these patients who are on very strict schedules of therapy. So across the country, there have been disruptions in cancer care for individual patients and individual and groups of patients that we're just starting to learn about what the significance of that is. So we know that patients who are being treated with surgery and patients who are being treated with traditional chemotherapy are uniquely susceptible to all sorts of infections, because both of those things really impact people's ability to fight infection and prevent getting infected. But, now there's so many different kinds of cancer treatment that we don't really know what the outcome is from all of them.
Yeah, Dr. Cannizzo, I mean, you articulated quite well from a medical perspective, but you're also a very kind person because I've met you. From a psychological, emotional perspective, if I had a major cancer, that's stressful enough, God forbid, and thank God I've never had to go through that. But you're dealing with something that's, in what you've said about the schedule, yes, and that would give me as a cancer patient some reassurance. Now that's kind of gone, and we're delaying treatment. You're talking about something that's highly stressful, to say the least, to begin with. Now you overdub that with the coronavirus, the pandemic. Talk a little bit about that in terms of your patient's perspective.
Oh, it is. I see it every day, and I still know in my heart that I can't ever fully understand what these people are going through. We spend all this time impressing upon our patients how important it is that we get things started, that we move on a schedule, that we reevaluate all the time. And now we're saying there are certain things that we told them are vitally important that we can no longer do, or that we can no longer do to the degree that we told them that we were going to. It's an extraordinarily stressful experience. And it's not even just those patients with really major cancers, because, if you had a pancreatic cancer, I would operate on you anyway. Even during the pandemic, we would take extra precautions and we would do what we needed to do. But, it's the thousands of women who are going to be, women and men, who are going to be diagnosed with breast cancer over the course of this year, who are going to be asked to wait until a time when the risk is lower. It's the thousands of men who are going to be diagnosed with prostate cancer this year. It's the thousands of people who are going to have a melanoma. It's all of those cases where we know that a short delay in treatment is not going to affect the outcome, but I can't personally imagine having one of those cancers and being asked to wait and not get it treated. I mean, it's an abominable situation. I know the numbers, and it's unthinkable to me.
Powerful point, Dr. Lopkin.
Yeah, you've been talking about the effect of delaying treatments, but given what's been going on with COVID, have we also been seeing, not just in cancer, but other conditions, a delay in diagnoses because people are just afraid to go into the doctor or hospital for fear of catching COVID?
Yeah, absolutely. So many cancer screening programs have shut their doors temporarily. Colonoscopies are moderately high-risk procedures for, spreading aerosols and the like. We don't really know what the risk is for disseminating COVID from colonoscopies. But there's not a lot of people who are willing to sort of risk it and to find out what those numbers really are. Mammogram centers, mammography centers have been reducing their workflow in order to keep the numbers of people in their waiting room down, so that on a monthly basis we're doing fewer mammograms, we're doing fewer prostate exams, we're doing fewer colonoscopies and upper endoscopies. So yeah, we're nationally accruing this gigantic backlog of people who are overdue for their scheduled cancer screening exams. It's going to take us years, if not decades, to really sort us back out when somebody declares this pandemic over.
That's really interesting, Dr. Cannizzo, that you're saying that. And what I was thinking about as you were going over this is that you have people that have, real conditions out there. Might be melanoma or prostate cancer. That might not be the quickest growing cancers. But I'm also thinking, as you're discussing this, people that are the untold numbers, people that are in their 50s and 60s that didn't get a chance to go get that colonoscopy or the mammogram or other things that won't be counted in this, but they're real, aren't they?
Oh, yeah, absolutely. We have no idea how many people, and I don't want to say this as an alarmist. I don't want to say this to scare people, but we have no idea how many stage 2 and stage 3 cancers we're going to find in the coming years that would have been visible earlier had we not been dealing with the risk of a rampant global pandemic.
Isn't that really the quintessential point in all this, though? That
absolutely
2-3 years from now, you're going to get people that should have never been at these stages but are.
Yes, absolutely. And unfortunately, some of the hardest decisions are around cancer screening, because the way that screening works, and I know you know this, but just for your audience who may not be familiar with the kind of the math behind screening, is that we try to look at a large number of people who don't show any signs of having a disease in the hopes of finding a few who have an early disease that doesn't have symptoms yet. So by its very nature, screening involves a large number of people who don't have anything wrong with them. So really, the benefit that we expect to get from a screening program has to be greater than the risk that we expose all of those people who have negative screening to.
Interesting. Dr. Lopkin.
Yeah, real quick, because we're almost out of time, and I'm not even sure if you can address this, but how are the medical systems going to come back from this pandemic? I was talking to somebody from Children's Hospital in Newington, Connecticut, and they were telling me that they've been losing millions of dollars a month on procedures that they can no longer, move through. How are the healthcare systems going to handle this and come back from it?
Well, I mean, I would love to address that in full, and I agree we probably don't have time for that. But medically, we're already working on national guidelines to prioritize people who need to be seen as early as possible and as often as possible as the risk of this pandemic decreases at whatever we consider to be the end of the pandemic. So medically, there's already a lot of work going on to advise people of how to prioritize the patients that they're going to schedule when the risk diminishes. The economic
Dr.
side of the
Cannizzo,
house,
it's been a great show. Dr. Lopkin, I think you would agree. We got to have you on again. And for our listeners and for the doctors, followers, and patients, how can they access this show if they didn't hear it live? You can hear both the replay as well as the Carnivore Bites podcast at xvadio.com/podcasts. You can also find us on the Apple Podcasts app, Google Play, Spotify, iHeartRadio, Stitcher, and wherever you find podcasts. It's been a fantastic show, and I can't thank you enough, Dr. Cannizzo. Dr. Lopkin, I think you would agree. Fantastic show. Fantastic. Thank you for coming on, and we hope you'll come back.
Oh, my pleasure. Anytime. Thank you so much for asking. It was a great pleasure.
Thank you.